Hello, my name is Chase Crihfield. I'm a paramedic student here at Wake Tech, the year 2025. This presentation is intended for the EMT scope, mostly for people looking to go beyond that scope, or just understand more about some of the medications and this acetylcholine route. Okay, so let's go into it. So we are talking about acetylcholine and its critical role in EMS. So just to give you a quick breakdown, because it's going to be mentioned later, we have two groups here. We have our acetyl group, which is right here. That acetyl group is called a functional group, and it's really going to be the primary component that's interacting with everything else, that's modulating what this whole molecule is doing and how it behaves in the body, pretty much what sites it's affecting. But we don't want to forget about everything. This is the body of it. This is choline right here. And it's an important base for a whole lot of neurotransmitters, hormones, and other components in your body. We're not really going to be talking about this much, but it is worth noting that this right here does a lot by itself. Introduction. Acetylcholine is a key neurotransmitter essential for both central and peripheral nervous systems. So just to break that down, we have our neurotransmitter. A neurotransmitter is any molecule coming from a neuron that sends a signal. So neurotransmitter can either be neuron to neuron, or from neuron to organ or muscular tissue, anything like that. And it's found in both the central and peripheral nervous system. So just as a refresher, the central nervous system is up here in our head, and our peripheral nervous system is all throughout our body. That's going to be all the way down to your legs, your feet, your spine. It's all peripheral. So understanding ACH is critical due to its systematic effects on homeostasis. You guys should be familiar with homeostasis. But this whole system, this ACH, has a lot of effects on it, on how our body regulates its homeostasis, which is why it's important. The other reason it's important is there's a whole lot of medications that affect this system, for beneficial and for adverse effects. So being aware of what's causing it, what's happening when you come into some of these symptoms, it can be very important. So what does it do, right? Acetylcholine is a neurotransmitter that has a critical role in both the CNS and PNS. ACH is responsible for mediating the parasympathetic response. So it regulates the parasympathetic response. And ACH is responsible for skeletal muscle contractions by stimulating at the neuromuscular junction. So you guys should be familiar with skeletal muscle, but the neuromuscular junction is just that junction between the neuron and the muscle. Seems pretty simple. It's where your muscle and your brain kind of communicate. ACH stimulates two main receptors, the nicotinic and muscarinic receptors. I'm going to be referring to these as an N receptor and an M receptor from here on. Just as a refresher, the parasympathetic function, the parasympathetic system, you're going to be your rest and digest symptom. So like when you're chilling out, not running away from anything, that's going to be your parasympathetic system. What does it do? So it regulates digestion, so it stimulates your digestive system to get going, salivating, more gastric secretions in like your stomach, peristalsis, like things moving through your small and large intestines. Your heart rate, so it's going to slow down your heart rate. You're resting, right? So it slows down, calm and relaxed. We love that. Respirations is going to constrict the bronchi, reducing airflow to the lungs. As you know, with the sympathetic nervous system, when you get all excited, your bronchioles dilate to let more air in. And this is just the counterbalance to that. It's supposed to close everything back up to its normal amount so you don't hyperoxygenate all the time. Urination and defecation, so it's going to promote that bladder contraction and bowel movements, aiding in waste elimination. Pretty much just you can get things moving out because you're not running away from anything. And it also affects sexual arousal. So our N receptors here, those are going to be found in those neuromuscular junctions in the autonomic ganglia. So the autonomic ganglia is really the bridge between the central nervous system and the peripheral nervous system. It's kind of like the gateway where everything goes. And it's also going to be in your adrenal medulla. So it's going to stimulate the release of epinephrine and norepinephrine, which are vasoconstrictors. The mechanism how it kind of does this is when ACH binds to the nicotinic receptor, it causes the channel to open, allowing Na influx and potassium efflux. So when your sodium influxes into the cell and the potassium flows out of the cell, that's called depolarization right there. It depolarizes the cell membrane of that nerve, which sends that electrical signal to the next nerve, which can either, with the next nerve, go to the nerve, or it could go to a muscular junction. And if it's at a muscular junction, it's going to cause that muscle contraction. So as we see here, it triggers muscle contraction or neural excitation, which passing that signal along. Our M receptors here is going to be our M1 receptor found in the CNS and gastric glands. So this is going to modulate cognition and stimulate acid secretion. Our M2 cardiac, this is where it slows down the heart and also reduces contractility. So going to lower blood pressure a little bit there, going to slow the heart a little bit. Yeah. Our M3 glandular and smooth muscle contractions. So it's going to be there in your lungs, it's going to be in your GI tract, in your stomach, all of that is smooth muscle, that organ tissue. That's all going to kind of like relax, get moving, get grooving, getting that digestion going. But just to get specifics, we have our bronchoconstriction down in your lungs, your GI mobility, that's that peristalsis, as things move through your small and big intestines, and our glandular secretions. So that's going to be your saliva, your tears, stuff like that. We also have our M4 and M5 located in the CNS. These are going to be mostly for your higher order processing or dopamine regulation. So these guys work mostly not by direct neural connections like the N receptors, but by activating G proteins that will then be released to go interact with the rest of the organ and regulate its function. So it's less of a direct connection. What happens when this gets really excited? This should look familiar to you EMTs, but we got our sludge M. So as you guys know, we have our salivation, so we have the activation of those M receptors, those glands. You got your salivation. You have your lacrymentation, tearing. Again, your tear ducts are glands, so those are going to be activated. You have your urination, so that smooth muscle relaxation, that's going to just let everything go down there. Your defecation and diarrhea. Your whole GI tract is just getting stimulated. Everything's getting going, and that's just going to push everything out. So a whole lot of diarrhea. Your gastrointestinal upset. So there with your stomach, you're going to have decreased gastric excretions. If you have any food in there, if you have a lot of water in there, that's going to upset your stomach a whole lot. It's going to end up pushing it all out. And that's where you get emesis. You get everything got pushed out, you're going to vomit. There's only one way to do that. And then with those N receptors here in the pupillary constriction, your iris is the main muscle that's responsible for pupillary constriction. It's going to be overstimulated, it's going to constrict, and that's why we have that. So here we have muscle fasciculations under additional symptoms. That's, again, with those N receptors, everything's getting stimulated, you're getting a whole lot of muscle stimulation going on. However, it's only kind of considered twitching because it's such a constant signal that your muscles don't have time to recover to make big movements. So as that constant signal gets out there, those muscles will try and recover, and they'll recover a little bit by themselves, but then they immediately get stimulated to go back out. So you'll see little twitches. You won't see like big seizure activity since it's not big waves, it's just a constant signal. The other things you're going to expect with overstimulation is that bradycardia, we slow down the heart, and the bronchorrhea. So broncho, your bronchioles, rhea, fluid, excessive mucus production in the bronchi. You have a bunch of glands for mucus production to protect your lungs of any debris or to keep all the lungs open nicely. You need mucus down there. Well, this is all going to cause a whole lot more to be produced. And obviously, that's not very good because we need our lungs to remain open and not full of mucus. And you're also going to have respiratory failure from neuromuscular fatigue. So your diaphragm is the major muscle responsible for your breathing, but also your intercostal muscles. Just like any other muscle in your body, I've mostly been gesturing at my hand, but also your lungs and your diaphragm, everything is going to be stimulated there, and they're eventually just going to give out, and they're not going to breathe properly. And this right here will kill you real fast. How do we stop that overstimulation? Well, that's acetylcholinesterase, and as we know, erase right there is mostly going to be an enzyme, and this enzyme is very important because it breaks down ACH into its base components, that acetate and choline I mentioned at the start of the presentation. So it's going to hydrolyze the ACH into those base components. Luckily, it does this very fast, so ACH has a very short half-life, typically, in our system. So your body sends out ACH to stimulate something. ACH here breaks it down really quick right after it gets that signal, so you have no problems. Unfortunately, sometimes it does cause problems. So we do have multiple medications or drugs or substances that affect this ACH activity. Over here on our N receptors, you have two main sites that we're clinically worried about, which is the neuromuscular junction and the autonomic ganglia. So obviously, we talked a bit about the twitching that you're going to see as the neuromuscular junction gets overstimulated, but also the autonomic ganglia, that's also going to be overstimulated. So you're going to have nerve impulses sent throughout your whole body, just constantly. Though it is to be noted that the autonomic ganglia is only affecting the sympathetic and parasympathetic nervous system, not sensory nerves, not heat nerves or anything like that, since those are a different system. What do we see when these happen? Neural excitation in the autonomic ganglia, so you're going to have an altered mental status, and skeletal muscle contractions. The medications that we have for this right now is acetylcholine and roconium. They're going to be responsible for paralysis for airway control and vasculations and paralysis. And our mucinic, I said that wrong, but our M receptor is going to be in our heart. That's going to be decreased heart rate. Atropine is going to be the medication of choice to fix this, and it's going to treat that bradycardia. It helps speed up the heart rate. We'll be going into more about what each medication does in the next few slides. The other receptor that we're worried about is our M3 receptor in the lungs, glands, and GI tract. So that's going to be our bronchoconstriction and our increased secretions. The major medication we have for that is iptronium. Mostly they're in the lungs, but it also will affect the GI tract, but it takes a lot longer to get there. But it's mostly going to be doing bronchodilation and airway support. Helps open your airway by kind of stopping this bronchoconstriction and reducing these secretions. It does have effects in the glands and GI though. So, as I said, sometimes this goes wrong, and those are cholinergic agents. So cholinergic agents are anything that mimic or enhance acetylcholine's activity. The ones that you guys should be familiar with as EMTs is organophosphates. So we know that organophosphates are found as nerve agents or in fertilizers and pesticides. So organophosphates are special because they inhibit ACHE, leading to a buildup of ACH. So as ACHE is inhibited, your body continues producing ACH. That's just going to lead to more and more overstimulation of those N and M receptors, leading to those sludge symptoms we talked about earlier. The medication that we really have to fix this is prolaxidone 2-PAM. It's going to reactivate ACHE and kind of start breaking everything down. The other medication that is in 2-PAM that you guys should be familiar with is atropine, which is going to block ACH at M sites. We'll be talking about that in just a second. Our other cholinergic agent here is acetylcholine. It's going to mimic ACH's function at the N receptors, causing continuous depolarization and temporary paralysis. So it hops right into those N receptors and just sends them off. Constant activity. Acetylcholine is also much slower to break down. It's still pretty rapid, everything considered, but it's much slower than ACH is by itself to break down. So you're going to end up with paralysis due to that, just constant signal being sent out. As I noted here, it's contraindicated in any trauma patient. So due to causing those tremors. Obviously with any trauma patient, you don't want to give them a little mini seizure. So we're not going to use it in that. Orconium is a competitive agonist. So this one is not a cholinergic agent. It is actually an anti-cholinergic agent. But it is going to not depolarize those N receptors, not going to send that signal, but it is going to stop ACH from binding to those receptors. That's why it's a competitive agonist. It would rather bind to those receptors and kick ACH off. It's not 100%, but it will still cause paralysis without that depolarization. Both of these medications are used in rapid sequence intubation. You guys as EMTs don't do this, but if you decide to progress on to paramedics, you'll learn all about that, why we do it. But understanding why these drugs are used and when to use them is really critical for airway management in these RSI procedures. So, anticholinergic medications in EMS, I already mentioned the Orconium, but an anticholinergic medication is any medication that blocks or inhibits ACH's effect. So atropine was mentioned just a little bit ago. It's going to competitively inhibit ACH at M sites, and it's used to treat bradycardia and organic phosphate poisoning. So you guys don't really use it to treat bradycardia, but it is in your 2PAM, so that's why I brought it up before. It's part of your organophosphate poisoning treatment because it occupies these M sites and really just buys time for the 2PAM to act properly and break down all that ACH that's in these sites. Paramedics will go ahead and use it for the bradycardia, and that's because it's inhibiting the parasympathetic nervous system from slowing down heart rate. So when your heart's too slow, we inhibit that down signal, and your sympathetic response is going to be more prevalent, so it's going to increase your heart rate. The other medication we have that affects this system is ipratropium bromide with the common name Atrovent. So Atrovent kind of gives you a little bit, it goes in the lungs. But it blocks ACH at the M receptors in the bronchial smooth muscle, leading to bronchodilation and reduced secretions in the lungs. So, ipratropium bromide, it's going to help open everything up, especially in patients with like COPD and asthma that are having that vasoconstriction, or not vasoconstriction, bronchoconstriction, and help just open everything up, reduce secretions that might be coming up, and keeping the airway clean and open. EMS is not the only system that uses these, nor is the hospital. So you will find at-home anticholinergic medications. Two big main ones is going to be Thorazine, which is a common antipsychotic medication used in children suffering from schizophrenia. This medication here is mostly used to inhibit hallucinations. It's been found effective to do that. So if somebody's suffering from schizophrenia, you can ask them if they're on Thorazine and know that they are on an anticholinergic medication and be aware of what certain side effects that medication would have. If you're going to give something else, know how that medication might interact with the rest of the system and that medication you're giving. One medication that you guys do give is Benadryl. So Benadryl will block acetylcholine from binding at receptors. This is where you're going to get that sedation effect of the Benadryl. It blocks ACH in your brain, you get the sedation effect, everything's cool, calm, and you feel like going to bed. This is not a comprehensive list of anticholinergic medications used in the out-of-hospital setting, but they are used to treat conditions such as diarrhea, asthma, motion sickness, Parkinson's disease, and COPD in an at-home setting. Side effects just to be aware of with these medications is going to be drowsiness, blurred vision, constipation, urinary retention, memory impairment, and confusion. So some pretty severe side effects, especially if people are chronically taking these. These side effects are going to kind of become more common. The clinical implications for EMS providers, what you should really just keep in mind, understanding ACH enhances the safe and effective patient care. You need to know how this system is functioning in people, what might be causing it. This is a major regulator for your parasympathetic nervous system. Awareness of ACH-related drugs effects helps prevent adverse outcomes. So knowing how your own medications are going to affect the body of the patient you're giving to, knowing how at-home medications might affect it, especially if you're trying to give another anticholinergic medication and they're already not going at home, can cause more side effects that way. Knowledge of cholinergic and anticholinergic interactions guides appropriate airway and cardiac management in emergency settings. So you guys don't really mess with these anticholinergic in these emergency settings, especially in airway and cardiac, but if you're working with a paramedic, knowing how these are used, knowing when they're used, and why they're used is pretty important. Just a cautionary note here, older adults are at increased risk of toxicity due to these medications, due to reduced liver and kidney clearance. You know, old people, everything's not really working at the same pace it's used to. They could have kidney failure, they could just have slower kidneys, hypertension, which impairs your kidneys, could have been drinking a lot, have liver failure, or just reduced liver functions. All of that is going to slow the rate that these chemicals are broken down in your body. They're going to have longer and longer effects. So in older patients, you really do want to be cautious about giving them too much of these medications. All right, here are my references. And that is it. Thank you so much for your time and have a good night.